Hi, good afternoon, everyone. Welcome to the Health and Social Services Subcommittee meeting on February 21st. We are going to be covering the Medicaid budget today, which is everyone's favorite topic. Until tomorrow, where we have everyone's favorite topic again. Thank you so much for joining us. As always, we will begin our review of the budget with our DLS analyst report from Anne Braun. So take it away.
Thank you, Madam Chair, members of the committee. My name is Anne Braun. I'm here today with the Department of Legislative Services to present the Medical Care Programs Administration budget, which manages Medicaid and the Maryland Children's Health Program. On the cover page, you'll see that the fiscal 25 allowance is about $12.2 billion, which is $425 million less than the fiscal 24 budget, mainly due to lower enrollment and utilization projections. I'm going to skip ahead to page 6. Looking at the exhibit 2 on that page, Medicaid and the Maryland Children's Health Program served approximately 1.7 million Marylanders as of December 2023. This exhibit shows that 87% of those participants are in the Health Choice Managed Care Program. The remaining 13% of participants receive services on a fee-for-service basis and are generally served in nursing homes or other institutions, or they are dually eligible for Medicaid and Medicare. In the Health Choice program, participants can choose from one of 9 managed care organizations, or MCOs, for their health plan. And as of December 2023, Priority Partners serve the largest share of all Medicaid participants at 20%. Moving on to the performance analysis discussion that begins on page 8. This first item discusses MCO quality performance. The department conducts multiple activities to collect quality assurance data and monitor MCO performance within the Health Choice program. The data DLS typically focuses on as part of this analysis are the HEDIS measures that are used by 90% of health plans nationally and allow for comparison across health systems. The aggregate findings for the most recent annual report for Maryland MCOs are listed on page 8, including that performance seemed to normalize and improve somewhat compared to the worst results seen during the COVID pandemic. The analysis notes that the annual report was published about 4 months later than in previous years, and that certain supplemental data that is typically included in this analysis to evaluate MCO performance was not provided at the time this was drafted. I will note, however, that MDH later did provide that supplemental data. MDH is asked to discuss the reason for the delay in publishing the annual report on HEDIS measures and to discuss Maryland MCO's individual calendar 22 performance. The next discussion on page 9 discusses accreditation status for the Maryland MCOs. The MCOs must be accredited by the National Committee for Quality Assurance to participate in Health Choice. 8 MCOs received accreditation based on calendar 22 results, but Priority Partners was placed on a provisional status and a corrective action plan. The department is also asked to discuss the requirements under Priority Partners' corrective action plan and whether the department is conducting additional monitoring and evaluation. The next performance analysis discussion has to do with the Population Health Incentive Program. This section covers the first year results from that program, which is a pay-for-performance initiative conducted by the department for MCOs. Before calendar 22, Medicaid administered the value-based purchasing program, which was designed to be budget neutral because MDH would charge disincentives or penalties to MCOs who performed poorly, and then those disincentives would be used to fund incentives for top performers. Under the new Population Health Incentive Program, the payment structure is incentive only and allows MCOs to earn up to 1% of their capitated rate payments for achieving certain performance benchmarks or for demonstrating improvement on measures that are selected by the department. For calendar 22, these measures related to participants' access to asthma medications, diabetes control, lead screenings among children, and other measures that are listed on pages 11 and 12. 6 of these measures are included in HEDIS measures, and the last 3 are developed by MDH directly. An annual report on this program has not yet been published, but MCO's performance on the 6 HEDIS measures were included in a December 23 annual HEDIS report. And so Exhibit 4 shows each MCO's results on those 6 measures only. MCO's results fell in 4 different percentile categories compared to the national HEDIS performance, and with any results above the 50th percentile being eligible for at least partial incentives. In this first year, all MCOs reported at least 3 measures rated as strong or higher that were eligible for an incentive payment. I'll highlight that 4 MCOs received at least 1 superlative result that places them above the 90th percentile in that measure compared to national results. Exhibit 5 on page 14 shows how $17.7 million in total incentives were paid out across MCOs. This shows that all MCOs received at least some payment, ranging from Aetna receiving about $300,000 to Priority Partners receiving the largest incentive payment at over $5 million. Considering Priority Partners earned the most in incentives despite its provisional accreditation status and corrective action plan, MDH is asked to comment on how this program's performance measures compare to the factors in the NCQA accreditation, and how the measures overall how the measures and the overall effectiveness of the program will be evaluated moving forward. The program allows for second round payments in cases where MCOs meet certain benchmarks, but in calendar 22, no MCOs earned a second round incentive. This left $20.5 million unallocated, and rather than distributing that funding to MCOs, MDH is carrying that funding forward to use in fiscal 25. The allowance, however, provides another $36 million in total funds, and that includes $11.7 million in general funds to level fund this program, even though that balance that they're carrying forward would be more than needed to cover the amount that they paid out in fiscal 24, that $17 million amount. DLS notes that the balance could instead cover calendar 23 incentives, and the budgeted $11.7 million in general funds could cover a portion of a general fund shortfall that I'll discuss and identify throughout this presentation. The next performance analysis discusses Medicaid application processing. This processing data is split between income-based eligibility groups who are processed by the Health Benefit Exchange and the more complex non-income-based groups who qualify due to their disability status or other characteristic, and those applications are processed by DHS. Timely application processing is especially important this year as Maryland conducts its unwinding from the COVID-19 public health emergency and the end of the freeze on disenrollments that was in place. And so for many Medicaid participants, this is the first time in 3 years or the first time ever that they're having their eligibility redetermined. Exhibit 6 shows, on page 16, shows that for income-based cases, the exchange processed over 93% of applications each month within 24 hours. The vast majority of these cases are auto-renewed based on information that the exchange has on file, and this process is referred to as ex parte renewals. Exhibit 7 shows that non-income-based cases take much longer, with at least 25% of applications processed each month taking more than 31 days, and a share of applications taking longer than 90 days each month. Non-income cases often have other requirements that prevent auto renewals through the ex parte process. And so in December 23, as an example, only 25% of the non-income based cases were reported as auto renewals. I'm going to jump ahead to the fiscal 24 discussion. On page 18, this discusses how the General Assembly added $3.5 million to the Medicaid budget in fiscal 24 to increase rates for abortion care services. MDH reported that an 88% increase for medical and surgical abortions and 19% increase for long-acting reversible contraceptives would take effect this month. Considering the delayed effective date, the department plans to use any remaining funds from this appropriation to distribute grants to those providers. On the next page, the proposed budget also includes a net increase of $197 million in fiscal 24 through deficiencies. The largest deficiency I'll highlight here is for $112 million, and that covers Medicaid services provided in fiscal 23 that are billed and paid for in fiscal 24. Providers are given a year to submit fee-for-service claims, and so there's a projected shortfall in the funding to cover those claims coming in later, and so that's what that $112 million would cover. Moving on to the discussion of the MCO Risk Corridor Agreement. This is a risk-sharing arrangement that MDH and the MCOs enter, or they entered it midway through calendar 20 to share in savings or losses when healthcare utilization was uncertain due to the pandemic. MCOs annually spend a percentage of their capitated payments on eligible medical expenses. That's referred to as the medical loss ratio. And that measure is then used to create bands in which MDH and the federal government would share in gains or losses with the MCOs, depending on what that ratio was. So Exhibit 9 shows the bands that were selected for calendar 21. And based on MCO's aggregate results in that year, MDH finalized state recoveries of $17.5 million that have not yet been accounted for in the budget. And so DLS notes here that these savings could offset some of the, again, the projected shortfalls that I'll be discussing later. Based on calendar 22 results, MDH estimated state recoveries closer to $15 million, but these won't be finalized until June of this year. The next fiscal 24 discussion discusses COVID-19 enhanced federal matching. The state received a 6.2% enhanced match on Medicaid spending that then created equivalent general fund savings. Exhibit 10 on page 21 shows that this provided substantial financial relief of over $450 million each year in fiscal 21 through 23. The Consolidated Appropriations Act of 23 established a phase-out timeline for this match, and so the first 2 quarters of fiscal 24 included a much smaller enhanced match before fully expiring at the end of calendar 23. The fiscal 25 allowance includes general funds to backfill the $85 million in claimed enhanced federal funds in fiscal 24, but this is more than offset by the impact of reduced enrollment and utilization that overall lowers the general fund need. Moving on to the fiscal 25 discussion, on page 23, Exhibit 11 shows how the Medicaid budget is split among the use of funds. About half of the budget supports the Health Choice Managed Care Program, and 29% supports medical costs covered on a fee-for-service basis. This includes nursing home services that account for 12% of the budget, and dental services that were recently expanded to cover adults, and that accounts for 2%. The list of proposed budget changes appears on pages 24 and 25. I'm actually going to just skip ahead and cover some of those major changes throughout this presentation. On page 26, there's a discussion of a BRFA item that authorizes a transfer of $216,000 in special funds from the Health Information Exchange to support IT activities. There's also an equivalent amount of general funds that would be reduced contingent on the spending authority for the special fund being extended. There is a technical error, however, and so the special funds aren't included in the budget, and the contingent language was instead placed on the federal funds in that program. And so as a result, DLS recommends 2 technical corrections. First, to strike the language that would reduce federal funds, and second, to amend language that would reduce general funds to match the name of the fund in the BRFA and to match the action in the BRFA, which transfers a fund balance. MDH is also asked to comment on when the $216,000 in special funds will be added to the budget to recognize the fund balance transfer. Exhibit 13 on page 27 reflects special fund support for the Medical Care Programs Administration. Here, I'll highlight the change in the Maternal and Child Health Population Health Improvement Fund. That fund received $8 million in fiscal 24, but is not budgeted in the allowance. This fund is supported through the HSCRC's Regional Partnership Catalyst Program and allows MDH to fund maternal and child health initiatives led by Medicaid and the MCOs. The funding continues through fiscal 25, but despite there not being special funds budgeted, and so MDH is asked to provide an update on when the $8 million in maternal and child health improvement special funds and then the matching federal funds will be added to the budget to recognize that spending. Let's see, I'm going to jump ahead to Exhibit 14 on page 29. This outlines the provider rate increases budgeted in fiscal 25. Under long-term services and supports providers, that group received an 8% accelerated rate increase starting January of 2024, but the allowance appears to only cover the annualization costs for nursing home services, and that leaves out approximately $13.5 million in general funds that would be needed to annualize the rate increase for the other long-term care providers. I'll also highlight that these rate increases are partially offset by a reduction of $25.9 million in total funds for physician evaluation and management fees as those are rebased from 103% of Medicare rates to 100% of Medicare rates in fiscal 25. Page 30 discusses the end of the MCO Rural Incentive Program. This program offered up to $8 million each year to MCOs who accepted new members in certain rural counties. The final payments under this program are being distributed in fiscal 24, after which MDH and Hilltop have developed a new methodology for a health equity index that will incentivize MCOs based on their enrollment in local jurisdictions with high socioeconomic disadvantage. However, the allowance does not continue the $8 million in total funds for this purpose, and that includes $2.8 million in general funds. So this also contributes to shortfalls in the Medicaid budget if they plan to move forward with this health equity incentive program. MDH is asked to discuss when the $8 million for the program will be allocated, the timing for finalizing regulations that would establish this new program, and whether the 2024 agreements with MCOs includes health equity incentives. Moving on to the beginning of the enrollment discussion, Exhibit 15 shows how Medicaid enrollment steadily increased by 25% during the COVID-19 public health emergency, while disenrollments were frozen. The department's 12-month unwinding process to redetermine eligibility for all Medicaid participants began in April 2023. And so that's why you can see in the fiscal 24 year-to-date enrollment through January, enrollment has declined slightly. In August, CMS noted that about 30 Medicaid systems were conducting ex parte or automatic renewals at the household level rather than at the individual level. And so this can lead to unnecessary disenrollments, as members of the same household could have different thresholds for being eligible for Medicaid. This is especially true for children, as they can qualify for the Maryland Children's Health Program with higher incomes. And so this especially impacted procedural disenrollments, in which participants are disenrolled because they did not complete the renewal process or they didn't have all the required forms filled out. Maryland was one of the states with this system error, and so in response, MDH paused all procedural disenrollments from August through October. The department reinstated 5,000 children to the program and worked on correcting the ex parte renewal system. Exhibit 16 on page 33 shows the monthly redetermination results. You can see that August, September, and October reflect the pause on procedural disenrollments. The Health Benefit Exchange and DHS did fix their ex parte renewal systems in November and December, and so those months show larger shares of procedural disenrollments as the pause cases are concentrated in those 2 months. Over half of Medicaid participants going through the redetermination process were renewed each month, and though the shares dropped slightly in November and December, again, that's related to the higher procedural disenrollments. Looking at Exhibit 17, for individuals who were disenrolled, this shows the breakout across reasons. Procedural disenrollments made up the largest share at about 64% of terminations. For individuals who were determined ineligible, financial reasons or income being too high was given as the leading reason for termination. That accounted for 20% of the disenrollments. I will note, despite there being over 238,000 disenrollments through December, the net change in Medicaid enrollment was actually lower at about a decrease of 74,000. This is mainly due to new enrollment and returning enrollment partially offsetting the disenrollments. Before the public health emergency, it was common for Medicaid participants to be disenrolled and then later re-enroll in the program, and that's referred to as churn. Hilltop analyzed redetermination results through December and found that between 28% and 33% of those disenrolled re-enrolled in Medicaid within 6 months. Hilltop did not follow disenrolled individuals, though, to see if they moved to other healthcare coverage, like qualified health plans that are offered under the exchange. However, the department has reported that it would monitor those disenrolled individuals for their coverage outcomes. I'll note, this is discussed on page 35, but there were funds in the fiscal 24 budget restricted until MDH submitted quarterly reports on the redetermination process. So far, half of that amount has been released for the first 2 reports. MDH submitted the third quarterly report in late January, and DLS found the reports to be in compliance with the language, so we would recommend you release the third increment of those funds. And so if there are no objections at this budget hearing, then we'll process a letter to this effect. MDH also publishes updates on enrollment changes and administrative data like application processing on its website. And it does this throughout the unwinding period. And so MDH is asked to discuss whether these published updates will continue after the unwinding process, and then to discuss whether new enrollment and returning enrollment or some other churn measure could be published on an ongoing monthly basis. DLS recommends adopting committee narrative that would request continued quarterly reports with Medicaid and MCHIP enrollment data continuing after the unwinding process. The last discussion on the unwinding process relates to certain strategies that MDH has used to ensure eligible participants keep their Medicaid coverage and that ineligible individuals are referred to other healthcare coverage. Part of these efforts have been applying for federal approval for waivers to change typical redetermination processes, and then there are also state-level changes that, as an example, the reconsideration period was extended out to 120 days, and that didn't require federal approval. One federal flexibility that Maryland received is to renew Medicaid eligibility based on participation in the Supplemental Nutrition Assistance Program, or SNAP. There was also legislation passed last year that requires MDH to establish express lane eligibility to enroll Medicaid participants based on SNAP eligibility. That would begin in January of 2025. And so since express lane eligibility is currently in place through the end of the unwinding period, MDH is indicated that it's applying for approval to continue this policy through calendar 24 to avoid any gaps in that policy. MDH is asked to provide an update on when federally approved flexibilities and state-level changes will expire, and whether the department is pursuing extensions or making any of these policy changes ongoing as part of the typical redetermination process. Exhibit 18 on page 37 shows enrollment forecasts assumed in the proposed budget and the forecast projected by DLS for fiscal 24 and 25. Considering the unexpected pause in procedural disenrollments and then the waiver flexibilities and other state-level policy changes, disenrollments during the unwinding process have been lower than anticipated. And so both forecasts expect fiscal 24 enrollment to be higher than was projected in the legislative appropriation. Fiscal 25 enrollment is projected to continue decreasing in both forecasts to annualize, and that's due to the annualization of the disenrollments throughout the unwinding period and due to favorable economic conditions. In the proposed budget, this projected enrollment and utilization decline accounts for the largest change of $442 million in reduced spending. Turning to the general fund adequacy discussion on page 38, because the overall enrollment forecasts in the allowance and in the DLS projections are pretty similar, there's minimal general fund impact from enrollment differences. However, the analysis notes that there are some large differences between the proposed budget and the Medicaid spending forecasts developed by DLS. The largest difference is that the budget currently underestimates spending on fee-for-service benefits for individuals who are dually eligible for Medicaid and Medicare. That is understated in the budget by about $105 million in general funds each year in fiscal 24 and 25. Other items contributing to the shortfall are the $13.5 million in general funds that are needed to annualize the 8% rate increase for certain long-term care providers. And then there's also differences in utilization assumptions that contribute to the difference in the projections. And so overall, DLS projects that the budget has general fund shortfalls of $115 million in fiscal 24 and $150 million in fiscal 25. Due to a couple areas of cost savings that I'd mentioned earlier in this presentation, that those total $29.2 million. And so the net deficits, if those savings are accounted for, would be $97.5 million in fiscal 24 and $138 million in fiscal 25. MDH is asked to comment on how it plans to backfill these general fund shortfalls. And so I'll move on to a brief discussion on personnel data on page 39. The Medical Care Programs Administration receives a net increase of 66 new positions. 22 of these positions are contractual conversions that were approved by BPW in October. There's an additional 12 positions in contractual conversions that'll be made in fiscal 25. Aside from these conversions, there's about 32 new positions added for the offices and programs that are listed on pages 39 and 40. I will also note that MDH reported a high vacancy rate of about 14% or 85.6 positions at the end of December. This is more than 45 positions over what would be needed to meet budgeted turnover, and so MDH is asked to discuss how it would spend vacant salary savings. Moving to the issues section that starts on page 41, this first one has to do with school-based health services. Medicaid can cover school-based services for students with individual educational plans or IEPs. They can also cover services through school-based health centers that would bill Medicaid as providers. And Medicaid could cover administrative costs to support schools in providing Medicaid services to their students. So that can include things like outreach too. As discussed during the Health Regulatory Commission's analysis, there is a BRFA provision that would allow the consortium for coordinated community supports to use its blueprint funding to reimburse Medicaid for the state share of school-based behavioral health services. MDH is in the process of applying for federal approval to expand Medicaid coverage of behavioral health services in schools and expects to implement this change in January of 2025. DLS notes, however, that there are no general funds in the fiscal 25 allowance for this purpose. And so if the BRFA provision doesn't pass, then there would be an estimated general fund shortfall of $12.7 million for the state share of these costs. Page 42 discusses administrative claiming. Maryland Medicaid used to implement an administrative claiming program, but the federal government found that there were significant numbers of improper payments. And so MDH paused the program or ended the program until there was updated federal guidance. CMS released updated federal guidance in May of 2023, but the department indicated that it will take extensive planning and technical assistance before a new program could be put in place. MDH did not provide a time frame for developing and implementing administrative claiming, and the fiscal 25 allowance does not provide funding for this purpose, and so the department is asked to clarify the specific process and timeline for developing a new administrative claiming program, including what specific tasks would need to be completed and the anticipated cost to the state and what the possible federal claiming amounts are. The next discussion focuses on school-based health centers. Those are generally led by sponsoring organizations that partner with schools to manage the centers. MDH provided a report on Medicaid claiming among school-based health centers that found that the number of centers billing Medicaid increased from calendar 21 to 23, but 72% of all billed visits were still provided by just 2 sponsoring organizations. School-based health centers reported multiple barriers to billing Medicaid. And so some of these are listed on page 43. This includes not billing for confidential services, not having accurate patient insurance information, and MCOs not recognizing centers as a self-referred provider, and then there were coding errors described. MDH discussed the efforts shown on page 43 to help with some of these barriers, such as ensuring that school-based health centers use electronic medical records, connecting the centers with the state's Health Information Exchange, or CRISP, and investigating MCO claim denial issues. The second issue discusses 2023 legislation that expands Medicaid coverage. The first highlights legislation that requires Medicaid to cover biomarker testing for diagnosis and treatment of diseases, as long as the use of biomarker testing is supported by medical and scientific evidence. This requirement does not take effect until fiscal 26, so there's no direct impact on the allowance, but MDH was already in the process of expanding biomarker testing for cancer treatment, and so that added an estimated $2.6 million to the MCO rates in calendar 24. But again, that's separate from this legislation. MDH indicated that the expansion of biomarker testing in the legislation was expected to have significant cost impacts, and the department is required to submit a report by December 2024 with an estimate of the fiscal impact and recommendations for any legislative changes to this requirement. I'll highlight too that there was legislation from last year that required Medicaid to cover gender-affirming treatment beginning in January of 2024. This is built into the calendar 24 MCO rate increase. There was also legislation that requires MDH to reimburse services under the collaborative care model statewide. This is also built into the calendar 24 MCO rate increase, so it is reflected in the allowance. Beginning on page 45, this shows the recommended actions from DLS. The first has to do with the Medical Care Programs Administration having 6 repeat audit findings in its most recent audit. So this is standard language that restricts funds pending a report on the corrective actions on those findings. Actions 2 and 3 are those technical corrections related to the BRFA item that authorizes the special fund balance to Medicaid that I'd mentioned. Item 4 is annual language that restricts funding for Medicaid reimbursements to that purpose and prevents budgetary transfers except for transferring over to the MCHIP program if needed. Item 5 was discussed more fully in the MDH overview analysis with the home and community-based services discussion, but this is committee narrative that would request a report on community options waiver and community first choice program spending and information on the waiver registry. Item 6 is committee narrative requesting continued quarterly reports on Medicaid enrollment changes after the unwinding process that I discussed earlier. Item 7 is a technical correction. This reduces an increase in MDH state employee health insurance costs because those costs are already budgeted centrally under the Department of Budget and Management. Item 8 is annual language that restricts funding for the Maryland Children's Health Program to that purpose and again prevents budgetary transfers except over to Medicaid reimbursements if that's needed. And so with that concludes my presentation. I'm happy to answer any questions.
Thank you, Ms. Braun. Any questions from subcommittee colleagues? Okay, you're off the hook. Great analysis. So we'll now call our Department of Health friends to the table. Secretary Herrera-Scott, Deputy Secretary Moran, anyone else you wish to bring, and you can proceed when you're ready.
Thank you. Good afternoon, Chair Shetty and members of the subcommittee. For the record, Laura Herrera-Scott, Secretary of Health. As always, to Ms. Braun, thank you for your, where did she go? There she is. For her detailed analysis. I also wanted to apologize for the delay in our written responses being submitted. So we certainly strive to get our documentation in on time, and as we do our due diligence to make sure we're accurately reflecting the most available answer and appropriate answer. Sometimes that causes delay, so I did want to acknowledge that. And before I turn it over to Dr. Ryan Moran, who is the Deputy Secretary for Healthcare Financing and the Medicaid Director, just want to say it was a very, very busy year for the Medicaid administration. As many of you know, during the public health emergency, all redeterminations were stopped, and prior to COVID, Medicaid was approximately 1.4 million Marylanders were receiving benefits through Medicaid, and by the end of the public health emergency, it was 1.8 million. And for some of those people that may have moved during the COVID period, they had not done redeterminations, even if they were enrolled prior to. And for some people, it was the first time that they became eligible for Medicaid, so they had never done the redetermination process. So it was a Herculean task by the Medicaid team to ensure that we were keeping as many people eligible for Medicaid enrolled in Medicaid services. So just want to talk about the complications of what we did over the last year. States had an option of 6 months versus 12 months, and we took the 12-month option, which will end in April of this year. And we did all this while putting in a new 1115 reentry waiver out for public comment, as well as expanding benefits for certain services, including maternal child health and certainly our trans community. So did want to call all that out. And with that, I'd like to turn it over to Dr. Ryan Moran to give his testimony, as well as provide some updates on our written responses.
Thank you, Secretary Herrera-Scott. and good afternoon, Chair Shetty, and to members of the Budget Subcommittee. It's really a pleasure to be here, and it's good to see you all again. We both, of course, want to thank you for the opportunity to review this. I will also echo my comments to Ann and the DLS team for their extraordinary work and their review, and the lots of back and forth over late nights and weekends in order to come up with this analysis. So thank you, Ann, for your support in a historic year that has been for Medicaid. I also, in addition to what the Secretary remarked, we also have slides for your availability, which I believe the committee members have printed. So I'm going to run through those very quickly. There are just 3, and then we're going to go over the DLS responses that were requested. So first and foremost, I just want to pick up where the Secretary left off and just to reiterate what a truly historic and unprecedented year this was for the Maryland Medicaid program. The work of the public health emergency unwinding or redeterminations or the renewal process, whatever you want to frame it as, this year has certainly been a Herculean lift for the 700 Medicaid colleagues that are working tirelessly to ensure that every single participant goes through the re-enrollment process. As the Secretary mentioned, states had the opportunity and the latitude to select their unwinding period. We chose a period of 12 months, and our administration has been laser focused to ensure that our North Star, our chief goal, is to ensure that every single person who's eligible for Medicaid retains their coverage. We have launched a comprehensive campaign in partnership with our MCOs known as Medicaid Check-In to help us in this regard. And the thing that I think I'm most proud of in terms of the team is we have taken advantage, we've been very aggressive as a state of taking advantage of federal flexibilities that allow us to ensure to protect enrollees. And also we've set up partnership referral systems with the Maryland Health Benefit Exchange for those that were deemed not eligible, that they could apply for or they could receive no cost or low cost coverage through qualified health plans. And also I would just be remiss if I didn't thank many of the people that are behind us here to testify as part of Medicaid's budget about the amount of stakeholder input that has been into this process and the efforts that we have done to work with churches in church basements, community-based organizations, federally qualified health center, providers of every shape and size, employers, schools, caseworkers, and that only just names a few to help us get the word out in this process. At the end of January, I'll just quickly note that Maryland has processed more than 1.25 million of those particular renewals, and we continue to lead the country with our renewal outcomes with almost 70% of individuals who have gone through the process who are deemed eligible. And as Ann noted, that while these numbers do indicate changes in enrollment from the 1.8 million Marylanders that we started with, our Medicaid enrollment at the end of January still stands at 1.682 million Marylanders. I'll move to the second slide, which I'll get into the specifics related to the fiscal year 25 budget. On those details of the budget investments, first and foremost, I want to speak to how this budget and the proposed allowance places a significant investment in the Maryland Medicaid administration, aligned with the Moore-Miller administration's priority to build back state government. The critical budget investment supports important functions in terms of human resources across the administration. And specifically, I want to highlight that it prioritizes our offices and programs where staff is needed the most in order to have a greater ability to operate the state's Medicaid program. This includes our Office of Finance, where the proposed budget adds accounting and financial operations staff. The other major area of investment in this space is the Office of Long-Term Support Services, and that goes in corresponding with an expanding portfolio and expansion of services along the long-term support services continuum that Chair Shetty, we talked about in that special briefing related to home and community-based services. On the next slide, I'll highlight a few other investments, and then we'll go to the DLS responses. The budget also includes a 3% rate increase for behavioral health, developmental disabilities, and long-term support services providers. These rate increases complement the work of the department that we are undertaking to ensure that there is the right continuum of services available for Marylanders in the right place at the right time. Further, this budget makes a significant statewide investment to improve access to housing for vulnerable Marylanders. We are prioritizing investments to address health-related social needs for low-income Marylanders through the current state program that we have known as Assistance in Community Integration Services. This initiative has been a critical tool for our state to better partner across state government, but to also leverage federal matching funds. I will also just highlight as a point of emphasis, and we're really proud of our team, Maryland was recently recognized as one of a handful of states with the Health and Housing Accelerator Award, where it will receive technical assistance from the federal government that will help us move this program from pilot to statewide, particularly with the budget investment that's made in fiscal year 25. And we will also have special focus in that particular technical assistance work to expand the program specific to populations for individuals with disabilities and older adults. I would also like to note another key priority as it relates to the reimbursement of school-based behavioral health services provided by Medicaid. Maryland Medicaid covers 700,000 children under the age of 19. It makes up 40% of our enrollment across the state. Our administration believes that strong partnership with schools can provide much-needed access and support, especially as it relates to behavioral health in an environment that is trusted by students and their families. And the department is making a concerted effort to look and to fortify the resources across the behavioral health continuum of care to ensure that we are investing in primary behavioral health and early intervention services to serve our kids. Specifically, I would note that the BRFA provision that's already been highlighted does create a new allowable use through the Consortium for Community Supports that aligns with the statutory provision of that particular group to maximize public funding and federal matching funds through Medicaid. And specifically, it allows for funds to be used for school-based behavioral health providers, psychologists, and social workers via Medicaid. And should that BRFA provision be approved, the department has two plans of which we will detail in our DLS responses. So with that, I'm going to move to responding to the specific questions. First, I'll just take the opportunity that we thank DLS for their insightful budget analysis and the recommendations that concur with the governor's allowance for the fiscal year 25 budget. I'm not going to cover all the questions, particularly the ones where there are technical corrections that the department agrees with. We're going to skip those. But I'll first start with the department discussing the reason for the delayed presentment of the annual report related to MCO HEDIS measurement results, and then also looking at comparing those results for the analysis by the department and how that compared in prior years. The first thing that I would note here is that the department changed our national HEDIS benchmark used in report in alignment with our Population Health Incentive Improvement Program. I will also note here that what we did is we now compare the current measurement year of HEDIS benchmarks to the current health choice performance year. So the delay in the report was reconciling those two particular timing differences of HEDIS measures versus how the department is monitoring that. And what I would also mention, and we talked a little bit about this last year, and we've talked to members of this committee, is overall in terms of the summary of those results from 2022, we do see that health choice MCO performance does decline, and we do think that that is continued ramifications from the pandemic. There are many factors that we have talked to related to that, including individuals who were delaying care, as well as providers being at capacity. But what I would also mention is that the Secretary and I, along with the Medicaid team, are working very closely with the MCOs on a multi-pronged approach in terms to improve quality and care for its members. The second question is the department should discuss the details of the corrective action plan for priority partners provisional accreditation, including whether the department is conducting any additional monitoring and evaluation. What I would note there is the department is meeting regularly with priorities to check into progress to come into compliance after they receive their provisional accreditation results. The responses note that the department believes that priority is on track to be in compliance with the standards, and specifically in terms of the provisional status, there were two items related to network management and credentialing that were issues that NCQA cited in that provisional status recommendation. The next is the department should comment on calendar year 22 PHIP performance and how that is used in determining accreditation status. and how we at the department are evaluating PHIP measures to improve healthcare outcomes. Of course, the NCQA accreditation process does consider the results of those HEDIS measures, as well as other performance results or organizational structure or network management, credentialing, things that I just cited as part of that. And I would remind you that the department has a multi-pronged approach in terms of measuring quality performance. The PHIP program that was new, that was talked about, is just one of those particular strategies. Another priority for the department is that we are trying to align all the different ways that we track quality outcomes and incentives across our programs, and particularly as the state moves forward in its application to CMMI for the AHEAD model that you've heard about. We are ensuring that those metrics align with MCOs and the accountability related to MCOs. Won't address the next two because those are technical corrections that the department agrees with. The next one is the department should discuss providing an update on the methodology that's used for MCO incentive payments to promote health equity, as well as how that is being tracked in MCO contracts and our regulations. So regarding the methodology for the Health Equity Index, MCOs do receive a proportion of available funding based on the number of members in jurisdictions that have highest levels of social determinants of health. So we take a look at particular metrics across the state related to food insecurity, neighborhood safety, housing, transportation, and the methodology aims to provide resources to MCOs in these particular jurisdictions where their members are. Also, I would note that we are in the process of updating our regulations to repeal the legacy Rural Access Initiative program and replace it with the Health Equity Index, and those should be finalized in May. And then our 2024, just a point of clarification, contracts with the MCO does include this methodology and lays out the payment structure as part of their contract. Thank you for releasing the funds as part of the next question. The second to last question on the page is we should discuss continuing updating enrollment change summaries and administrative data on CMS, as well as adopting additional data reporting. What I would say there is throughout the course of the unwinding period, let's not go back to the pandemic. Throughout the course of the unwinding period for Medicaid, we have been one of the most transparent states about sharing our redetermination data on our website, including now broken out by race and ethnicity, jurisdiction, zip code in terms of the highest of procedural disenrollments. CMS has certain requirements that we are to report, and we have every indication to believe that actually even beyond unwinding period for states, that CMS is going to continue to require that reporting, or at least some type of that reporting. So we will ensure to keep this committee updated and continue to report on metrics. I would also just note, historically, Medicaid has reported on its enrollment in a number of different ways, including online, part of our Medicaid Advisory Committee, and other forums as well. And of course, we can work with our team at Hilltop Institute to add additional measures as requested by DLS, specifically around new enrollments, net new enrollment, and returning enrollments to the program to our future data summaries. The next question is about the termination dates of our flexibilities that I mentioned, and whether the department is continuing to pursue extensions on incorporating those flexibilities. MDH, just as a reminder, we will keep those flexibilities in place until the end of the unwinding period. And yes, there are some that we will be looking at to extending. The one that was cited by Anne is the flexibility of renewing individuals on SNAP with Medicaid eligibility. That actually comes with a legislative mandate, express lane eligibility for the renewal process. And we have appropriately submitted all the authorities from the state perspective that we need, both state plan and 1115 waiver, into CMS to continue that after unwinding period. That has been the biggest protection and safeguard for Medicaid participants. Just pulled the numbers, more than 150,000 individuals through our unwinding period have retained coverage because of linking SNAP and Medicaid eligibility. So that one will continue. We also know that there may be other measures from CMS that would become permanent, And so we will be monitoring those as well in terms of anything that's required to remain in place. Department is asked to comment on general fund deficits of 97.5 in 24 and then in 25. I think here we would just note that the department thanks DLS for identifying a budget issue involving premiums paid on behalf of individuals who are dually eligible. That was a result of a formula error into utilization data into these particular projections, and the department will be working with the Department of Budget Management on additional budget solutions if they are needed. I will move to the last two questions on school-based reimbursement. The department is asked to comment on the 25 allowance does not include general funds for the purpose of school-based behavioral health services, and the failure to adopt the BRFA provision would result in a shortfall. The department, of course, acknowledges the need for budget authority to implement behavioral health services to be reimbursed for Medicaid, as we have outlined. The BRFA, as we've stated, does create that particular allowable use. The department does support the BRFA provision that we feel strongly, clearly aligns with the consortium's existing statutes, and leveraging Medicaid dollars to make strategic investments to improve behavioral health for our kids is something we think is very important. We'll just note that if the BRFA isn't approved, the department will work with DBM to assess the feasibility of implementation and the corresponding timeline. Then there are a series of questions that look for the department to respond to the proposed new administrative claiming program for school-based psychologists and social workers as part of our plan. With the consortium, we have very detailed outlined 2 phases of this work. The first phase, as we note, is expected to be in 2025, hence the allowable use. For the administrative claiming portion of that, I'll just note that that is a much more complex endeavor. We are working both with the consortium to receive technical assistance for that particular work, to ensure that we're partnering very closely with MSDE and the local education authorities to do administrative claiming and the work that's appropriate and to do it right. We are also, this is a big priority for the Biden administration, and they have allocated funds to state programs to go after federal resources to support technical assistance for administrative claiming, of which we will be submitting a federal application in March for that particular work as well. And we anticipate, because of the technical assistance needed and the complexity of the administrative claiming procedures and processes, that sometime in 26 and 27, that portion of the phase will be turned on, if you will. So with that, thank you for your patience and for listening as we went through those particular results. And the Secretary and I are happy to answer any questions you may have.
Thank you so much for your thorough and thoughtful response and for the important work that you have done during this incredibly challenging year. I just want to start out with just a really quick administrative item. Madam Secretary, thank you so much for acknowledging the delayed response. I know it seems, procedural in nature to have these just 2 days before, but our entire subcommittee is so committed to the work that we share together that we spend several hours preparing for every single budget committee hearing that we have. Now, it doesn't pale in comparison to the thousands and thousands of hours of work that each of your agency staff members do to actually do this work and serve our constituents, but it gives us an opportunity to have such a great conversation with you during these hearings if we're all able to come prepared. And so I ask if you wouldn't mind please taking an opportunity to review any barriers you might have had to submission of that 2 days prior, so that going forward on the remaining budget hearings, if we can get those a little bit earlier, it really does give us a better opportunity to have a great conversation. So
We'll make sure the rest of them are on time.
we really appreciate it. Okay, so that was my quick procedural question, and then want to see if any committee colleagues have questions. I see Delegate Asfero had his light lit first. Go ahead.
Thank you, Madam Chair. Good to see you, Secretary Herrera-Scott. Question, I've received a good bit of emails from constituents about the Medicaid reimbursement, specifically ensuring that we keep it at the 3% reimbursement. something that's pretty critical. Gotten some emails about it the past couple of months. And so just wanted to see if I could get some sort of a commitment from you or your department that that Medicaid reimbursement will remain at 3%. As I'm sure you're well aware, there's matching federal funds, and so that could potentially be in play with the Medicaid. So just wanted to see if you could provide a response.
So there was a 3% increase in rates for long-term care providers, for behavioral health providers, and disability providers. But for the E&M codes related to primary care services, as an example, those were brought to 100% of Medicare due to limitations in the budget. Now, we are actively looking at that. Because as part of the next negotiation with the total cost of care model, there are expectations on primary care investments. But at this time, I cannot make that commitment to you because they were funded at 100%. So it is a slight reduction than what they were getting in last year, if those are the codes that you're referring to. Mm-hmm. But one that we're actively in discussions with in DBM moving forward because of the expectations of the next total cost of care model.
Gotcha. We'd love to follow up with you about that. And then lastly, Madam Chair, wanted to follow up on a response I requested from the Office of the Medical Examiner. Mm-hmm.
We are preparing a written response. That's great. I think what we thought we, sure. Yeah, no, that's in the works, but we wanted to prepare a written response so you had it in writing.
Thank you very much.
So that's in the works.
Thank you, Madam Secretary.
Thank you, Delegate, for the great questions. Thank you, team, for the wonderful responses. I just want to flag, I also share an interest in the E&M code challenge, so I'm really grateful to hear that you all are looking at this in light of the AHEAD model work that you're doing. So just putting a pin in it that I'd love to hear continued feedback on how that is going as you're going through that process, if
Absolutely.
I may. Thank you so much. So I will now turn to Delegate Heinbaugh for questions.
Thank you, Madam Chair. I had a couple questions, but your response to the DLS analysis was pretty thorough, and you answered those questions. One was about the budget shortfalls in 24 and 25 for, was it 115 and 150? I think you talked about that. But during the course of your presentation, you mentioned something about an initiative that would provide access to housing. I think you said that. Could you just talk about that very briefly?
Yeah, so it's known as the Assistance in Community Integration Services. It is part of a pilot demonstration that dates back to, I want to say, 2016, 2017. Historically, what that pilot has done, there has been up to 900 slots in terms of individuals taking advantage of that, of intensive housing case management resources to provide individuals with a pathway for stable housing. The pilot program, we just did an evaluation with our partners at Hilltop, has shown tremendous results. People who have gone through the program, 80% of them got and remain stably housed, as well as there's been a reduction in terms of spending and visits across the healthcare system, emergency department spending, et cetera. So there's been a full analysis on that. What this particular investment does, Delegate, in terms of the fiscal year 25 budget, is it ensures that that program is increased in terms of a statewide. So right now it's limited to 4 or 5 jurisdictions. And so it allows for slots to be statewide. And we will be working with our federal partners at CMS to increase those particular slots to the program now that we have state funds in order to bring down the federal match.
So will your capacity increase from 900, or would that 900 just be spread over a bigger?
Yeah, so 900, and I believe the estimates that we have currently is somewhere around 2,300 across the state now with that $5.4 million state investment.
That's great. Thank you very much. Thank you, Madam Chair.
Thank you, Delegate. Thanks for the response. Delegate McCaskill for a question.
Thank you, Madam Chair. Thank you all for being here. I'm pretty sure your responses took on a huge task, so congratulations to you to be at this point. My question is referring to page 29, Exhibit 14, the rate increase for LTSS providers. I'll give you a second. So in the DLS analysis, it notes that there is, for FY25, an allowance that includes, what is it, $59 million for your annualization, which is a rate increase for nursing homes. So my question is, let's see. The increase only covers the cost for nursing home providers, which results in a $29.8 million shortfall and $13.5 million in general funds. So could you all just speak to that and share how you'll plan to correct that technical error? Or
Yeah, so we note in the analysis there was a technical area related to that particular shortfall. I just want to note that there was an 8% increase effective here, as it says in January 1 for LTSS providers, and then in July 1, 2024, the proposed is a 3% increase for those providers.
Okay. Okay. Thank you, Madam Chair. Thank you. I appreciate that.
Okay, thank you. And then just so my understanding is correct, the technical error that DLS noted specifically speaks to a shortfall that results because it doesn't annualize, the FY25 allowance doesn't annualize across other providers. So your response is that you all are working on it, or that
Correct.
It's, okay, great. Okay, thank you. Any other questions from colleagues? If not, I have a couple. Delegate McCaskill, do you have further questions? Okay, that's okay. Sure. Thank you so much. Okay, so first question is related to the PHIP incentive for the FY25 allocation. So MDH has allocated $36 million in FY25 for the incentive payments, but DLS has noted that the department is carrying over $20 million from unallocated funds from prior years. So it sounds like in 2022, the amount that was required was less than the current unallocated funds balance. Could you use those carried over dollars to fully fund PHIP? Do you require an additional $36 million on top of that for FY25?
So the PHIP is a 1% outside a capitated rate. It's incentive-only program. I think the results previously, as mentioned, we did not spend the entire pool of those particular dollars for the 22 performance. And I believe what the DLS analysis says is the opportunity to carry those funds in terms of covering general funds shortfalls in the future, if I'm understanding your question correctly.
Right, but then FY25 allocates an additional 36 on top. So you need 56 to cover PHIP incentives for FY25?
No, so it would just be, I don't have the number off the top of my head, but it's 1% of the capitated rate for MCOs, or overall capitation.
Okay, can we follow up so I can get that number, please?
Yep.
Thank you so much, sir.
And that's the maximum, right? So there's
Okay.
a certain threshold that MCOs must meet in order to receive those payments.
Yeah.
That's also documented. There's 2 particular rounds of those. Here's round 1 of those payments, and then in order to qualify for round 2, there's a certain other threshold as well.
Got it. Okay, very helpful. Thank you. I appreciate the follow-up later with that info. So my last question, since you all beautifully covered the ahead model question that I had planned, is related to, I know this is a subject that continues to come up. We talked a little bit about it a year ago in this budget hearing. I think this has been a perennial issue for like 10 years, but it relates to the reimbursement rates for anesthesiologists providing dental care and Medicaid. So we flagged it as well during one of the briefings we had with HGO, and I'm just curious if you can please provide any updates on your plan there.
Chair Shetty, I'm not going to leave this room without giving you an answer.
Thank you. I appreciate that.
There are a number of different questions. So let me just say a few things, and we're running some data and finalizing a report that also was part of HGO's briefing that you're attending as well. But number one, and you rightfully commented that historically the budget language that was proposed back in 2014, 2015 was never honored. It was also intention language in terms of looking at that budget closely in terms of that to be funded. Secondly, what I would say, and we're happy to sit down with you and others to talk about this, is the department continues to believe that Medicare is the appropriate benchmark for that. There are challenges, particularly for dental services, when you start looking at the commercial rate data being available to make appropriate percentages as that intention budget language set out. Third is we have pulled data and happy to share it with you as well in terms of looking at the specific code that sort of has been in question over the course of the past 10 years to understand the growth, because the investments that the state has made in dental services in recent years have gone to prevention and restorative codes that we hypothesize would believe the need to be less for intensive procedures in this particular area. And what we have seen is we haven't seen a growth in that particular utilization of codes when you track it with enrollment. And fourth, what I would say as we continue to have this conversation is that the department is, as we reported to the Health and Government Operations Committee back in December, we are finalizing a report on pediatric dental access. And we requested for HGO to have a couple of months in order to work on the finalization of that report. I only bring it up because part of that report will specifically look at this piece of stipends that hospitals pay anesthesiologists to provide those particular services. And that's an important factor when we think about looking at this issue and continuing to have conversation about it in the future.
That's super helpful. Sorry, I'm taking a lot of notes, a lot of good data here. Sorry, I will come right back to you. I just want to finish this line of questions if you don't mind. So thank you so much for your work on that report and your thoughtful response. If you wouldn't mind also sharing that report with us when it's complete, would really love to stay in the loop on this issue. I know that I understand and hear where you're coming from related to benchmarking to Medicare, but as you're aware, Medicare rates are continuing to decline. So the delta between commercial rates and Medicare rates is continuing to grow. And I'm a little concerned about what that could mean to access. And so I know I'm not alone in that concern. And I know we talked a bit about that in the joint hearing with HGO. So I thank you for your continued work on this and hope that as part of the report, you might consider also including a little bit about the delta between the rates and what that means. And Delegate McCaskill.
Thank you, Chair Shetty.
Thank you.
That's exactly where I was going. I appreciate it, Madam Chair, because I want to kind of put this in a human perspective. So I have been talking to many of folks, include constituents and some folks who had called the office. And I was also speaking to just a young lady who was in Walgreens getting some pain meds. And she, along with other conversations I've had that have come to my office, was having a conversation with me about not having anesthesiologists available for any of her oral procedures. And so when she went in to get her oral procedures done, she had to opt to just have local anesthetics, and they continuously administered local anesthetics to her as her procedure went on. If she raised her hand to say, "Okay, I feel it, I'm in pain." And so, on a human perspective, and you all tracking and taking things into consideration and reimbursement rates and all that Madam Chair spoke on, I just think that this is a necessity because we having folks who are going into dental offices who are not able to have access to an anesthesiologist. There's none on the premises. And this seems to be happening over and over again throughout the state. And folks have to get the medical procedure done, but then there's no anesthesiologist, and then they are freaking in pain. And so that's quite a concern. I wouldn't want it to happen to me or none of us in here, that they have to deal with the pain versus having that access to an anesthesiologist and just having to go local when getting major medical dental procedures done.
Thank you for that. Without knowing the details of the particular person that was speaking to you and the dental work that she was having, anesthesiology is not indicated in all dental care. So we will certainly respond to the details that you provided in the rates, but it's hard to comment any more than that based on the conversation that you had, because the dentist advising her at the time, local may have been appropriate. Now, not everyone tolerates local for a variety of reasons, fear of needle, fear of just having someone working in your mouth, et cetera. But we can certainly look at that as part of the codes that Dr. Moran was mentioning.
Preferring to have it, but just not having access. And more so, one of the conversations the dentist office did say is that they just weren't available, and because they weren't being reimbursed at certain rates, so they decided to opt out and go elsewhere. So that's a real big concern for folks out there. Thank you.
Thank you, Delegate McCaskill. Thank you so much, MDH team. Any final questions for our MDH friends? Okay, congratulations, you're done. We do have quite a few individuals signed up to provide public testimony. Some have submitted written testimony that is in your record, committee colleagues. So I'm going to call 4 at a time to join us at the table. And I'm just going to go in the list based on the list that's provided to me. So Kevin Lindemood, Healthcare for the Homeless, Dan Shattuck, Barbara Mercado, Joseph DeMattos. Great. And you can go in any order you wish. Please identify yourselves for the subcommittee members here, and you can consistent with committee guidelines, each of you are afforded 2 minutes, timed by our wonderful counsel here, Mr. Gutbertlet.
Excellent. Good afternoon, Madam Chair, members of the committee. I'm Kevin Lindemood, the CEO of Healthcare for the Homeless. We're Maryland's leading provider of integrated health services and supportive housing for families and individuals experiencing homelessness, operating clinics in Baltimore City and Baltimore County. We're here in support of the Medicaid budget and the department's leadership team. Medicaid remains such a critical resource to improve the health of people experiencing homelessness and to end homelessness altogether. Expansion of a decade ago has been absolutely transformative. If you heard the news cycle this morning, even the 10 reluctant states that have not yet expanded Medicaid are showing signs that they may do so. We're grateful to the department and this body for supporting further reforms such as adult dental care, gender-affirming care, coverage of pregnant people regardless of immigration status. Just this morning, I learned of an undocumented pregnant woman who tested positive for HIV at our clinic. Because of this new expansion, we were able to start medications the very next day to prevent spread of HIV to the child, who, as we all know, will be born a U.S. citizen. In particular, we applaud the Moore administration's inclusion of the successful Assistance in Community Integration Services pilot, or ACES, otherwise known as the Supportive Housing Waiver. Deputy Secretary Moran gave a fantastic description of the program. We contract with the City of Baltimore to provide intensive services for 300 households. And as you heard, a 5-year study from the Hilltop Institute found statistically significant reductions in emergency department visits and hospitalizations. We thank the Baltimore hospitals who collectively have covered the local match to draw down federal funds over the last 6 years, and we're thrilled that the program will be continued and expanded statewide. We strongly encourage a favorable review and full support of this Medicaid budget. Thank you.
Madam Chair, members of the committee, Barbara Mercado, and here on behalf of the Maryland Society of Anesthesiologists, and wanting to thank this committee for their commitment to looking at the issue of Medicaid and anesthesia. Just quickly, but I have to go through the history. 2007, tragic death, DeMonte Driver. The state had a dental program that was not considered one of the better ones in the country. Then Secretary John Colmers put a dental action committee together. They formed a dental action committee. They incentivized the dentists, surgery centers, everyone but the anesthesiologist did they incentivize to participate and make this program work. In 2009, when the program went into effect, the anesthesiologists were being paid $17 a unit. And I don't know their average charges back then, but it was way, 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 way below. We met with the department starting in 2009 saying anesthesia needs to have nearer market rate reimbursement. Didn't get any positive response from the department, didn't. In 2015, the General Assembly put budget language in 40% of the commercial rate. Let me say that dentists, back when the program went into effect, when it started, dentists got like 100% increase. Their reimbursement is based on average charges. Now, saying the dentists need money, I know they haven't had the fare increases, but dentists have gotten increases, AmSurge centers have gotten increases. We've sat here and advocated while all the other players have gotten increases. The anesthesiologists, when the language was not honored by the Department of Health, the Department of Health did go from $17 to $23 a unit, which was Medicare then. Medicare now is $22 a unit. Medicare is looking to go down 3.5%, which means that the anesthesiologists have not gotten a raise in 10 years. It's gone down.
Thank you, Ms. Bricado. I'm so sorry, but that is the 2 minutes. I know you have your colleague, Dan Shattuck, here too.
I just want to say that Medicare is not a fair benchmark. Can I say, our docs do not want stipends from the hospitals. They want fair payment. Thank you. We're here to work on this, get it fixed. Thank you.
Thank you.
Hi, Madam Chair, members of the committee. Dan Shattuck here today to speak on another issue related to Medicaid rates, and it deals with maternal fetal medicine. We have been working with our client, they're called Pediatrics, their national medical group, but they have a strong presence here in Maryland. They staff 11 hospitals. In particular, they staff 6 NICUs, and they have 7 outpatient maternal fetal medicine specialty centers. So maternal fetal medicine, the bare minimum explanation is they are the superstars in the at-risk pregnancy world. They work with the moms who are at risk with their pregnancy because of high blood pressure, diabetes, maybe they're having twins or triplets, maybe they've had a history of miscarriages. They are there to help manage complications and work out the best outcomes for mom and baby. Over 70% of the patients that they see in the state of Maryland are Medicaid patients. We are applauding the state's action in increasing and expanding accessibility under Medicaid to pregnant moms, in particular the expansion that Mr. Lindemoon mentioned. It's going to yield positive outcomes and better maternal outcomes and better infant mortality outcomes. We are just asking, we know it's a tight budget year, we're appreciative of the E&M codes being looked at by the department. And maybe this is not a this session thing, but we want to look at increasing some of the rates in the maternal fetal medicine space that haven't been increased in over 10 years. It's an important thing. We know the state is very focused on improving maternal child health and outcomes. We're here at the table. We want to be part of that discussion and keep making improvements. Thank you.
Madam Chair, members of the committee, Joe DeMatos, representing the Health Facilities Association of Maryland, in support of the budget, the 3% increase. First, I want to say thank you all for meeting with Hope Morris and members of the association this week leading up to this hearing. I also want to say that you have my written testimony, so I want to summarize, but I will say this at the onset, and that is that this budget, in the first deficit that we've encountered in a number of years, is a profile and courage for Governor Moore and for each of you. In April, I would have been at this job and will be at this job for 15 years. I came in at the start of the Great Recession, and we cut nursing home rates by 8% because we had to. Looking back, I think those types of cuts were very dangerous and really led to us being where we are today. So why is the 3% so important? I'll tell you. Essentially, it's a cost of living or inflation increase. Whereas occupancy in Maryland skilled nursing and rehab centers hovered in the 90th percentile before the pandemic, in Maryland we're at 83% now on average. And costs, as you can see from my testimony, have skyrocketed. Additionally, agency costs for care, which made up only 2% of the staffing dollars, prior to the pandemic, now account for almost 30%. Now, getting back to the occupancy numbers, Maryland's at 83%. The country is about 5% less than that. But let's talk about it specifically and locally. Delegate McCaskill, Baltimore County is at 87%, but there's a high penetration of nursing homes. So it's all over the map. There are nursing homes at 40%. So if you're at 40% occupancy, but your costs of operating are 150% of what they were previously, that's just bad math in terms of access to quality care. Delegate Heimbaugh, if you drive beyond the gap and you look at Garrett and Allegheny counties, when the statewide average is 87, it's 77% and 74% occupancy in those counties. And when you look at specific nursing homes, it's down to 40, 50%. And finally, in Montgomery County, it's the same challenge that we have in Baltimore County, Baltimore City, and any of the other larger counties with high penetration. The averages are actually higher than the statewide average, 87% delegate in Montgomery County, but there are nursing homes all over the map. So I just want to say this 3% is small, but it's critically important, and I'm able to answer any questions about the previous 8% or 4% or anything you want to ask. Thank you very much.
Thank you so much, panelists, for your testimony. Do any subcommittee colleagues have questions? Thank you.
Delegate, thank you for your gallant service. Appreciate it.
We're going to count that nice comment against the next 2-minute testimony you give, sir. Just kidding. Okay, so I think we only have 2 other witnesses providing oral testimony today, Jill Pelovitz and Dana Kaufman. I know Dana reached out to my office and shared that she's juggling a couple of hearings today, so it might just be you, Ms. Pelovitz. While you're settling, just want to note to subcommittee colleagues that we do have written testimony from Pyramid Healthcare, Inc., as well as Healthcare for the Homeless in our folders for today. Thank you. You may proceed.
So before I begin, I brought a picture of my daughter, Nadia. She's in school today, so, and yes, the fascinator is in her hair, her choice. So, and when I'm finished, I would love to walk around and show you the picture so that you can kind of put a face to the story and the name. So good afternoon, delegates. My name is Jill Pelovitz, and I'm here not just as a citizen of Anne Arundel County, but as a parent whose child is directly benefited from the rare and expensive case management program and care coordination services at the coordinating center. I am deeply grateful for this opportunity to share our story and to highlight the vital importance of the REM program. Nadia is 19 now, but she was born with a rare genetic disease that causes multiple disabilities, including cerebral palsy and life-threatening intractable epilepsy. She requires full support. Despite her profound level of disability, Nadia is a happy person who loves Disney, dogs, fashion, and classic rock, with Fleetwood Mac and Steely Dan being her all-time favorites. She inspires hope in everyone that she meets. REM has provided life-saving nursing support. As Nadia is transitioning into adulthood, the need for REM has become even greater than ever. Her case manager at the coordinating center is a lifeline, connecting us to services such as therapy, specialists, and equipment. She's that calm voice who's there to sort out all of the pieces, and she helps us find solutions. Nadia has always been the focus of her work with us. Adult services are very daunting, but knowing that our REM case manager will be there to help us navigate the health piece is a relief. Continued funding is essential. It is through our personal experience and gratitude that I urge you to continue funding for the REM program. The services provided are truly life-saving, and demand is ever growing. The program is facing challenges. There are long wait lists, and there are nursing shortages. And without adequate funding, many families like ours will miss out on the transformative support that has been so crucial to us. So in closing, I want to thank you for your continued support of REM. And people with disabilities are often the group that's left behind. Many, like Nadia, are nonverbal and they can't speak for themselves. I will tell you their caregivers are exhausted. Nadia needs support for her survival, but she also needs it so that she can continue to inspire hope to everyone that she meets. Thank you.
Thank you so much for being here today. We really appreciate it. Do any colleagues have questions for our amazing witness who's walking around today? She's beautiful. Thank you. Okay. Thank you so much for sharing your daughter's story and the important work that the rare and expensive case management caseworkers do to support her. That concludes the witness testimony as well as the budget hearing for today. Colleagues, tomorrow, as you know, we will be hearing the DDA budget. I know many of us have many meetings today with many advocates who are here. So we are done for this afternoon. Thank you. See you all tomorrow.